Afternoon, right after lunch. Hopefully we've got some folks that are still awake. I hope I'm still awake. Lunch always kind of slows me down. Greetings from Cleveland. Thank you for the extraordinarily kind and unnecessary introduction. Let's see if I can even figure out up here how to move the slides along. Got it right, perfect. Perfect, good. This is, for me, this is a really neat opportunity to be here with you all today. When I got the invitation, I kind of took a double take. I was like, wow, that is cool. I remember a little over 10 years ago when one of the few times I left my comfort zone in Cleveland and came out to Baltimore to do that Master of Public Health. I thought, man, it would be neat if someday I can find a way to apply some of these things I'm learning about to sort of our healthcare system. And to be able to get invited to give a talk at Medicare is just really neat for me and exciting personally. So I'm really honored to be here. Probably I'm the happiest guy here now. And I'm also, this is like a tropical vacation from Cleveland right now. So I think it's worth, for me, just thinking we're here really discussing the Medicare and Medicaid policy and Medicare program, how we take care of Medicare beneficiaries. And I think it's worthwhile to go back to sort of that founding mission of the program that President Johnson, laid out on the inauguration of the Medicare program, that the program reminds us never to spurn or ignore untended suffering. And I think that in the home health world in particular, if ever there were a group of providers in the Medicare program who are focused on mitigating untended suffering, in my view, in my experiences, it's been folks in the home health world. And so I think that this area of care is vital to achieving the mission and vision of the Medicare program as it was founded by President Johnson. So who am I? I had a very kind introduction. I appreciate the warm words, and really, truly, I think that the most interesting thing personally that I can share that I've done is I've gone out and made some home visits. And it just so happened when I was finishing up my residency training that there was an opportunity to start a home care practice. I took a picture of one of the neighborhoods from one of the neighborhoods near my hospital where I started doing the home visits, and I just got out on the road and took the black bag, if you will, in the van. I started out with a Chrysler, but once the kids were born, I had to get the minivan. And it works well for the house calls too. And sort of getting a sense of what's going on with our patients in their homes, a lot of times being asked to get involved with situations right after hospital discharge or difficult situations. And it's been very instructive for me. And I think really just sharing some of my experiences might be helpful for these efforts to improve the quality of care. And this is a difficult challenge. One of the health quality gurus, Don Berwick, in some of his writings and speeches about healthcare quality, uses the story of the 1949 Man Gulch forest fire in the Montana mountains, where the smoke jumpers came in, but it turned out, although it seemed like it was going to be an easy fire to put out, the winds changed and they were really caught in a life-threatening situation. And as the story goes, as Berwick retells it, that one of the foremen had the idea to burn a patch of land ahead of the fire, and that they could at least, the firefighters go escape in this burnt patch of land as the fire blazed by. And I believe only the foreman and maybe a couple of the other firefighters followed this fellow's lead into this burnt patch of land, but it turned out to be a very creative and successful way to manage a fire, a term known as an escape fire that I guess has become part of modern firefighting. And what Berwick has advocated is that in healthcare we need escape fires. that include interventions that rely on the best evidence, that provide unencumbered access to care, and that enhance healing relationships. And I think that it's a good story. We are definitely in a forest fire, if my estimation is correct, vis-a-vis care, particularly for vulnerable Medicare beneficiaries. We are in a forest fire. We're going through a period of time where we're going from about 30 million or so Medicare beneficiaries to more than 70 million from the 2000 to 2030 range. And these folks are aging with chronic conditions and activity limitations, 90% having at least one chronic condition, about 70% having two or more coexisting chronic conditions. Point prevalence in the 65 to 75 age group of, this is a young group, of being able to transfer, 10% having an ADL deficit in transferring. In our 85 and older group, more than half having difficulty with walking. And because of the prevalence of obesity, diabetes, arthritis among our current cohort of younger adults, it's not likely that that ADL curve is going to change a lot. So we are having a growing population of older adults with multiple chronic conditions, many with activity limitations. And this is happening as we're discovering this unsustainable cost curve that, gone unchecked without change in behavior, I think the latest Congressional Budget Office projection that I'm aware of has the Medicare and Medicaid programs accounting for nearly 10% of our gross domestic product in that 2030 to 2040 decade if nothing changes. And a few points to make about those expenses. The expenses seem to be focused to an extent on high risk, higher risk beneficiaries, those with 5 or more coexisting chronic conditions accounting for more than 60% of program expenditures. And very concerning patterns of regional variation in health spending that don't seem to be related to the quality of care as best we can measure. Lots of challenges. In spite of the spending, in spite of the high spending, there's a lot of suffering. Many of the folks who are the subjects of the spending, they are suffering, often feeling like their care is fragmented. They may get conflicting recommendations from different people in different settings. They fall into, as Eric Coleman is called the no care zone, or they're suffering in between billable events, is another term that's been used to describe the experience that some of these high-risk, low-mobility patients experience. So, and doctors are often frustrated about what to do, sometimes feeling powerless. Our medical training and models were often developed to deal with acute problems and to deal with singular problems, the heart, the lungs, an infection. When there is such multimorbidity and so much social overlay, we're often frustrated. There's literature to support that. So I think that we are in a forest fire, if you will.